Welcome to this week's edition of Freedom and Prosperity Radio. We're the weekly radio news magazine put together by the Virginia Institute for Public Policy, what I like to refer to as a do tank. I mean, you've heard of everybody's got a think tank. Not everybody has a do tank like the Virginia Institute for Public Policy. Just check out Tuesday morning group coalition meetings, find out about being a member, our education efforts, our efforts in election integrity, and it's all online at virginiainstitute.org. Joining us now, Director for Policy for the Virginia Institute for Public Policy, Caleb Taylor. Caleb, welcome back. How are you doing, sir?
Thank you for having me back, Joe. I'm really excited.
And this is after reading Terry McAuliffe's healthcare policy? You're really excited?
Oh, even more so.
Well, I know he just tweeted that he would be in favor of mandating Virginia businesses forcing their employees to take experimental medications as long as they're called COVID-19 vaccines. Mandates must be in here somewhere. So tell us what you found.
It should be noted that McAuliffe has two different health plans. He has an affordability plan. He has an accessibility plan. Both of them are massive, lots and lots of different planks. I feel a little bit like they were written in hopes that nobody would read them.
Oh, that's always a good thing.
And it's I recognize some of the problems that he's wanting to solve, and I agree that a lot of these problems need to be solved. But the way about he wants to solve them, I just for the most part think of as being very kind of unserious efforts at solving these issues.
It's rare. I mean, it's been probably 10 years since an elected office seeker has actually been able to come up with a real tangible problem that many people could agree on. So, that in and of itself is sort of unicorn-like in this. So what are some of the things that we can agree on were actual problems first, I guess?
Well, I think that we agree on that accessibility is an issue. Around Virginia, there are a number of places that they, I hate this term, but they refer to them as medical deserts. And yes, there are a number of places. This is largely due to the fact that when doctors either graduate in the state of Virginia or move to the state of Virginia, they tend to concentrate in the cities in Richmond, in Northern Virginia, and they don't really kind of spread out. There's good reason for this. Money itself is not the reason.
Okay, that's often the argument, though, is that they do it because it makes them.
Well, they're doing it for more. They're doing it for more pay and more consistent work, which is completely reasonable. The issue is solving that issue is not. It's an unserious proposition to just suggest that we can throw money at the issue and it will solve it.
Okay.
And frankly, I've gotten to the point now where any policy recommendation that boils down to throw more money at it is just an unserious policy recommendation.
Sure.
And I'm just not interested in them.
But it's so common. I mean, I think that's also his transportation policy, Caleb.
It is common, and it's going to be common in the political realm. I mean, it's something that often gets people's attention. We're gonna bring down all that federal money that we deserve. And do what with it? That's the question. What are you going to do with it? We're going to give it to this regulatory body or that regulatory body or this local government or that local government. Okay, and do what with it?
Well, that's
question.
If you were in the press, you'd of course not be allowed into the press conference if you were going to ask such a question like that. But let's poke around that, because I remember in the good old days when the most controversial thing that happened in Washington or Richmond was either Obamacare or the associated Medicaid expansion, and the subject of medical deserts came up, and some of it was policy. Researchers were pointing to insurance policies, tort liability policies that were, inaffordable unless medical professionals partnered up and joined sort of these group offices, which I think the expression was kind of did in the old country doctor.
Yep, this is exactly what's happened. And this is the problem with the kind of the policy arrangement of pour more money into the system. When you do things like this, you create what I refer to as market mutations. People tend to focus where the money is, and people tend to serve the entity that's providing the money. If the entity that is paying for the service is the consumer, then the producer will serve the consumer. If the entity that is providing the funding is the government, then the producer will serve the government. This is how this works, and it's a major problem, especially in our healthcare system, with a massive percentage of all healthcare being run through Medicaid and Medicare programs, and this is only getting worse. The issue is, and this is something that I agree with Terry on. The issue is over the last number of years, this has created what he likes to refer to as equity issues, where this unfortunately very distinctly affects affects largely black neighborhoods in the state of Virginia. There's a lot of people who, when they think about this, black and Latino neighborhoods, when they think about these minority neighborhoods, they make the assumption that these neighborhoods are located in Richmond. And that's not the case.
Oh, okay.
The vast majority of Black and Latino neighborhoods are focused just south of Richmond in the rural areas, kind of in southwestern Tidewater, and then right in the middle Atlantic coast region of Virginia. Both of these areas are rural, and we're effectively stripping doctors away from them, stripping service providers away from them, but we're not doing it with the idea of we're not doing this because of more money or anything else like that. We're not keeping money from those areas. That's not what's going on. Right. What's going on is we're making it extremely difficult for providers to set up shop in those areas. This goes back to our, decades-long fight against certificate of public need in the state of Virginia.
Oh, sure, yeah.
This is a major problem.
It's cost of compliance too, isn't it? You talk about the insurance and the regulations that would govern it. Even if it almost becomes where you wait for an Inova or a Centaur to say, well, we'll set up a clinic there. And usually that's something that the government's going to have to cajole them to do anyway, isn't it?
I mean, that's essentially what's going on, yes. Between regulatory cost and the fact that, down the street in Richmond, VCU can shut down the building of any new hospital, 15, 20, 25 miles away, because they don't want to have to compete with them, again, via this certificate of public need program. That becomes a major issue.
Oh, sure. We see it in our flagship city. There are two hospitals, but one predates the other. But I'm sure if University of Virginia had its way, and I'm told that there were some things that when Centara purchased Martha Jefferson Hospital, there were some questions as to whether UVA could invoke its certificate of public need over the purchase and or the relocation of the hospital to a different area. And it's not for a lack of trying that they did. And you see it with clinics, you see it with MRI, and it is to the detriment. You mentioned these poor communities. I mean, and we could extrapolate out how these communities become poor because there's the attitude among many in the elected office class that these are there because racism, and it's often much more economics that these neighborhoods have lost whatever jobs were there when they became neighborhoods, and now they're sort of just there wandering around wondering, okay, will there be a new convenience store opening soon, and will they pay better than the last one?
Yeah, that's a major part of it, and I don't necessarily think it's racism. I think it's the fact that I think a part of the reason is we have this, or a lot of people often have this thought that these neighborhoods exist inside the inner city, and that's just simply not the case. Right. And once we recognize that they're in the rural areas, that they're focused in the rural areas, which rural areas don't tend to be, one race or the other. We have black rural communities, we have Latino rural area communities, we have white rural communities, we have diverse rural communities. They're spread out all over the place, but all of the rural communities are being underserved because of these regulations.
Caleb Taylor is on with us. He's Director of Policy for the Virginia Institute for Public Policy. He's published a research paper on the McAuliffe health plans, digging into them, and he's taking us into his analysis. So what does the former governor's plan do to address this accessibility? You had mentioned throw money at it. Is he throwing money to try to get doctors to open up in these places, or what is the plan to deal with these rural areas that are being underserved?
That's the question.
Oh gosh. Fundamentally, the repetitive kind of, and there's essentially two. Most of both plans, and don't get me wrong, I want to give him credit where credit due. He has a couple of good planks too, that both parties should just use because they're good, but. The majority of both plans is one of two things. Either it's, I'm going to support this program that's already state law because Northam already signed it into law. Okay.
Which doesn't seem like a new idea at all.
Right. Because
it's not.
Yeah.
And the other one is we're going to make sure we get that federal money here for Virginia. But there's no real, when he's talking about equity, it's these age-old programs or programs that he started way back when that clearly from his own rhetoric aren't working, and he thinks that more money is going to fix it, and that's ridiculous.
Right.
There's no if he had gone with much fewer planks, maybe one plank in accessibility and one plank in affordability, and actually really discussed what that money was going to do, we'd have more to talk about. But they don't really do that. I've been sitting here. The analysis that we've put out is a policy analysis. And I've been working through a cost analysis, which is extremely difficult because he's so vague about what money will be used, how much money will be used, what it'll be used for, that it's... If I tried to put out a cost analysis, the vast majority of the numbers I'd use are just completely made up. I'd have to just make assumptions.
So this plan is more aspirational than tangible.
Yes, which makes me think that it's not something that is really we can expect it to actually be met.
Mm-hmm.
I'm not sure that we can really expect something like this to be met. He could not even ever get the federal funding, reallocate $50 and say we got more funding.
Well, what about what always seems to happen when I hear a politician talk about affordability of health care? They use phrases like allocate funds and redirect expenditures and things that often sound like somebody's trying to keep me from looking behind Bernie Madoff's accountant's desk. Is this just a game of three-card Monte where he's going to say, well, while you're looking at healthcare, I'll move money out of VDOT, and then when you look at VDOT, I'll move money out of healthcare and that kind of thing?
Well, and I don't know. The Virginia state budget can be complicated at the best of times. The governor does have some sway over how money is spent, but I don't think, but not really so much sway that he can drain VDOT's account and give it to healthcare, right? That's really still going to be the General Assembly that handles that. But he does have there is discretionary funding in each of these silos, right? Mm-hmm. That he can kind of move around if he needs to. And we've seen that with Northam. Northam's done that. I'm sure every governor's done that over the last 100 years. But it's kind of one of these things that's just even this kind of discussion about if we spent money better, mm-hmm. or if we allocated it to the right resource. These are unserious policy suggestions. One of the ones that I think is a very serious and important policy suggestion in McAuliffe's plan, and I'm 100% sure that as Youngkin puts out his policy stuff, that he'll be in support of it too. Is the solidifying the COVID waivers for telehealth and codifying them and making telehealth like a part of the game permanently.
Okay.
And I think that's a good idea. That's a fantastic idea. It's something I've been working on for 5 years because I believe in it. It's something that the people at the big hospital at UVA and VCU tend to agree with, and even small hospitals agree with. I mean, telehealth, it's been shown numerous times that telehealth in conjunction with in-person practice creates a much more efficacious and cost-effective healthcare model. Mm-hmm. Great. I think we're all on board. So that's a real policy position. And if there's some kind of budgetary concern that needs to be addressed in order for that to happen, sure, it'll happen in the General Assembly. We don't even need to talk about it in terms of the the policy setup, right? Mm-hmm. Because the policy setup itself is, let's make sure these waivers become permanent. Let's make sure they're codified. We know now, after COVID, after 2020, 2021, that that the use of telehealth works, and let's make it happen. Okay, that's a real policy.
No, it is, and it can actually invigorate these rural communities, although I certainly can hear the follow-up, which is now we need government broadband to these underserved rural communities.
Of course.
Because we've regulated the marketplace so much, there isn't any.
Yeah, I think, and I think that there's a conversation to be had about that deregulation. Sure. There's also a conversation to be had about, what effect 2020 Zotard rules will have on the expansion of wireless internet, mm-hmm. In the rural communities. I mean, this is actually a conversation we've been having recently. Is why are we continuously talking about broadband instead of just talking about generally high-speed internet?
Right.
What about
was it Sky-Fi that Elon Musk has been deploying for the last 2 years now?
Oh yeah, and apparently the beta testers for it out in Wyoming and Montana I actually have this strangely met friend in Wyoming who I stay in contact with, and he's one of the beta testers, and he says, I didn't even know internet could be this fast.
Wow. Yeah.
But he had been used to like 1 meg download speeds, right? I hadn't seen that since DSL.
Right.
And so, I mean, yeah, there's a lot of new innovations coming out of that. The federal government, in some ways, has gotten out of the way of those innovations. And I expect to see just like a growth of high-speed internet. I don't think we need to have the conversation only from the point of view of broadband, rather than the point of view of the differing ways of high-speed internet. Let's support or get out of the way of the development of high-speed internet in the rural areas, and then move on from there.
Well, and to go back to the healthcare, this would be like somebody saying, well, we need to get better leeches into the doctor's hands rather than do all this antibiotic stuff. Or saying, well, we need a government bill to make better, faster buckboards to compete with these automobiles. It's saying that the old is better than the new just because some places hadn't gotten the old yet. There are people in China who have never seen a landline phone because they went from no phones to cell phones, and they have no idea, what it means to have a phone mounted on the wall, because that just never existed in most of, especially the working class parts of China. Caleb, are there things you said there were some good planks, and I think we've talked about a couple of them in this healthcare proposal from Terry McAuliffe. Are there things that, and I want to make this clearly, I'm curious, is this just a campaign document, I guess is what I'm saying, or is this something that if he's elected come that January in 2022, this starts to become actionable policy in the waiting rooms of our hospitals?
I think probably the former. I think this is a campaign document. The reason we wanted to do an analysis is because we're under the impression that these campaign documents that both sides tend to put out are useless, and they don't help the situation. I mean, having reasonable expectations among the average Virginian is a really important thing. It changes the way our expectations change the way that we spend money. It changes the way that we set up our insurance. It changes the way that we purchase gas. I mean, everything. Having those kind of reasonable expectations and these kinds of like really unserious policy, like it literally, they threw the spaghetti against the wall, see what sticks. And it's generally again and again and again, we're going to support stuff that already exists, or we're just going to spend more money. It's not a reasonable stance to be at. And we at the Virginia Institute would really, really encourage all candidates from both sides, or all sides would be even better, to produce policies, ideas that are serious policy ideas, so that we can actually sit down and debate them reasonably. And this is mostly, we went plank by plank in these two plans, which is an immense. I mean, I think the analysis got upwards of 20 something pages. I'm not sure, but it just plank by plank, hitting every single plank. And the vast majority of them, it was always the same answer. This problem is caused by COPN. This problem is not caused by a lack of money. It's caused by regulations being in the way.
But I gather his solutions are never, let's get rid of those regulations.
Oh, no, not a single time. And I don't see it's kind of one of the things that kind of hurts my feelings about kind of the political situation we're in between Republicans and Democrats at this point, because it used to be that there were certain regulations that both parties would go out to stop. It's like the Democrats would go after certain regulations, the Republicans would go after other regulations, and we had much more kind of balanced way of dealing with things, and these were real policy suggestions, whether you agreed with them or not.
Right.
And that's I'd really like to go back to that just a little bit. I'm not one of these people that really kind of yearns for the good old days, but really just more of that would be great.
Well, yeah, sure, because then you're saying, okay, here's a place we've discovered that, whether unintended or not, our efforts have impeded something. So let's stop that. Because sometimes, the best intentions, I see it. My grandfather was a zoning commissioner, but I can see places where zoning and land use and planners are used as ways to stop development rather than encourage it or to make sure that it's holistic for the whole community.
I mean, you're absolutely right. And this is the reason why we added, and it really is kind of our job to add policy recommendations to things, but this is the reason we added these specific 4 policy recommendations to this analysis. We've already talked about COPN, we've already talked about telehealth. But the other 2, which is increasing the scope of practice for nurses, midwives in the state. We've got really, really limited scope of practice for certain types of medical professionals, which make no sense. Our RNs and nurse practitioners are highly, in any other country in the world, they'd be considered doctors. They're right. Highly effective. And it makes no sense that they shouldn't be able to practice on a much kind of wider scale.
Right, because right now, if I'm not mistaken, they have to be associated with a doctor in order to practice. They can't just hang out a shingle and see patients.
That's right, and some of them should be able to do that.
Right.
Some of them are at a level, and not just a level of education, but a level of experience that I don't see why a nurse practitioner who's been in the business for 15, 20 years could not go southeast of Richmond and set up a little clinic.
Sure.
I don't see any reason why that's a problem. Especially considering the major issue with medical deserts is not mo money. It's purely supply and supply allocation.
Right.
Which when I use those words, I don't mean so we need the government to come up here and reallocate these supplies. I'm not suggesting that at all.
Send the deuce and a half with more supplies, and no, that's not it.
What are they going to do? Just pile up doctors into the deuce and a half and drop them off? Okay, you guys live here now.
There are some people where that is the model. And you read some of the human infrastructure bill in Congress right now. And you said there was another suggestion, another policy recommendation, Caleb?
Yeah. So the last one has to do with Virginia's licensure by endorsement program. Have you heard of this?
No.
So the licensure by endorsement program in Virginia was set up to allow doctors from outside of the state, doctors and medical professionals from outside of the state to practice inside of the state.
Okay.
What it essentially is originated as is if a doctor moves into the state of Virginia, or is in a reasonable distance away from Virginia, like 50 miles into Tennessee or whatever, and wants to practice in Virginia, they can gain endorsement by their own board of medicine and come to Virginia with that endorsement and very quickly, supposedly, receive their Virginia license.
Okay.
Not a whole lot of rigmarole, was meant to be like a streamlining effect. Unfortunately, we've gotten reports of people all over the state, nurses, doctors, and other professionals who are allowed to use this licensure by endorsement that are saying that it's taking 9, 12, 24 months for this program to actually get them their license.
Wow. That's incredible.
It's absolutely ridiculous. And with the expansion of telehealth, what we really want to be able to do is make this much, much easier. Essentially creating a time limit by which the Board of Medicine is allowed to spend considering this 30 days, 60 days, something along those lines, where at the end of that they have to say yes or give clear reason why not.
And if failing to do so, would that be considered an affirmative? Because I've seen these bureaucracies just sit on something and say, sorry, we haven't gotten to it yet. That if you don't make the 30-day window, that's considered an affirmative would be what I'd like to see on that.
Yeah, and that's exactly right. We essentially would like to create this opportunity for the Board of Medicine to make this program a lot faster, especially in our new age of telehealth, where we can get doctors from all over the United States who maybe they themselves have difficulty. Maybe they have a wound or a particular medical condition that keeps them from being in the office. Maybe they'd like to just serve as doctors via telehealth from their home in Idaho. And do this licensure by endorsement, and now they can practice via telehealth in Virginia and offer their services to in-person brick and mortar doctor's offices as a triage service or whatever else. This is kind of an important thing. Now that even CMS up at the federal level, the Centers for Medicaid and Medicare Services, they even recognize the value of this and have started putting out payment codes, generic payment codes for telehealth usage. Okay. And I want you to understand how important it is, how significant it is that they put out these generic codes, right? They're not super specific. They're a lot more generic. This is really super useful even inside the kind of government healthcare system.
Oh, sure. I can see that. I ran into a fellow once at Freedom Fest, the Scouson's great event in Lost Wages, who actually did almost an Airbnb version of healthcare where you could book a surgeon. It brought down if a surgeon happened to have nothing going on that day, you could book them, or maybe not Airbnb, but more like a hotels.com for doctors, where they would find doctors who had nothing on their schedule that day, and you could actually book them for a much lower price than if you went through your whichever Shield, the blue one or the other blue one that you went through.
No, I think that's absolutely fantastic. And there are actually a couple of hospitals in and around the United States who operate by this kind of pattern. There are cash hospitals. There's one, I can never remember the name of it, but it was started by a doctor out of India who was also the doctor to Mother Teresa. Wow. And there's a number of these hospitals around the world, one obviously in India, but there's one in the Caribbean. And the doctors there are like Emory doctors. I mean, they're not like fly by night, Antarctica University like docs. They're your standard, high standard docs. They do everything is cash pay. There's no insurance allowed or anything along those lines. But they're doing open heart surgeries of $1,400-$1,500.
What?
Yeah, cash.
Holy cow!
Not only that, because they've been incentivized to innovate because they're cash only. The doctors that work in a hospital see roughly 800% more patients because the hospital is so efficient with that doctor's time.
Interesting.
The only time the surgeon is in the room is when that patient is already open.
So they make use of all the other healthcare professionals, whether it be a nurse practitioner, a general nurse. wow, physician's assistant. Again, once it becomes, what did you say at the onset, Caleb? When an economy is being paid by somebody, that's who they'll serve. If it's the consumer, it's going to be that. Holy moly!
That's right. And I've met people whose lives have been saved by going down to these types of hospitals. Not when I say their lives have been saved, I mean the word life in multiple ways. I don't mean just their physical. Life. I mean, their financial life too.
Sure. So the most important question that I have: can we take Freedom and Prosperity Radio and rebase it out of the Bahamas?
That is a question for another woman.
I was just thinking, that would be a tough gig, wouldn't it? Hey, Caleb Taylor, and people can find this at virginiainstitute.org and download these reports there?
Yes, you'll be able to download those reports, and we'll be sending them out kind of to everybody as well. All right. Well, we deeply appreciate the research into this. And again, it's not yay or nay. It's here's what the policy should look like, and then compare to what all the politicians are offering, and see how that compares. Educated consumer is our best customer is a subtext of the Freedom and Prosperity Radio program. Caleb, you have a wonderful weekend, and thanks for taking some time out with us. Thank you so much again, Joe. And don't forget about that Bahama post. Oh. What, the mic's still on? Gosh, guys. We'll be right back with more Freedom and Prosperity Radio in a moment.